Alhamdulillah wa salali rasulillah. Assalamu alaikum wa rahmatullah. My name is Amber Khan, Education Chair for IMANA. It is wonderful to be back hosting the IMANA Education webinars. We had a little bit of a break with Ramadan, so it's wonderful to be back. It is currently May and it is National Mental Health Month. And so in light of that, tonight we have a very special guest, Dr. Rania Awaad. She will be speaking about connecting communities, integrating mental health into a faith setting. Before I introduce her, I would like to share that in 3 days, this webinar will be available for 1 CME credit for any of you who are attending for that purpose. You will need to register on our LMS system at med.imana.org, and there will be a course available for enrollment by the same name as the webinar. If you have any questions, you can reach out to me with my contact information or contact IMANA, and we can assist you. And I'll share that information in the chat as well. So tonight, our speaker is Dr. Rania Awaad. She is a clinical associate professor of psychiatry at the Stanford University School of Medicine, where she is the director of the Stanford Muslim Mental Health and Islamic Psychology Lab, as well as Stanford University's affiliate chaplain. In the community, she serves as executive director of maristan.org, which is a holistic mental health nonprofit serving Muslim communities, as well as the director of the Rahma Foundation, a nonprofit organization dedicated to educating Muslim women and girls. Dr. Rania is also faculty of Islamic psychology at Cambridge Muslim College and the Islamic Seminary of America. She is also a senior fellow for Yaqeen Institute, as well as the Institute of Social Policy and Understanding. And prior to studying medicine, Dr. Rania pursued classical Islamic studies in Damascus, Syria, and she holds certificates and ijazah in Quran, Islamic law, and other branches of Islamic sciences, mashallah. You can follow Dr. Rania at dr.rania Awaad. And without further ado, Dr. Rania, when you are ready, you are welcome to share your screen and take it away. Jazakallah khair.
Wa iyyakum. Thank you so much, Dr. Amber. Assalamu alaikum wa rahmatullahi wa barakatuhu. It's really wonderful to be here with IMANA and doing these webinar series, particularly as Dr. Amber mentioned, it is May, which is Mental Health Awareness Month, mashallah. And I think it's a wonderful time for all of us to really kind of talk a little bit more about the topic of mental health, in particular, talking about, of course, what it means for a Muslim community in specific and working with Muslim patients. And so that is my goal with us, inshallah, today. This is what I hope to address with you all, how it is that we can best integrate faith into our discussion of mental health and really health practice in general, inshallah. So welcome again. And on behalf of those in my lab who contributed to this presentation, which I'd like to just give them a shout out, and the folks who helped kind of make some of this research that we're going to present to you possible. I'm really excited to kind of share that we have an ongoing project this year and next year focused on religious and spiritual clinical competencies in care, in clinical care. And what that means is there's different teams across the country that are working on what are these religious and spiritual competencies in clinical care for. In our case, we're working on Muslim communities. Other teams are working on Christian communities, Jewish communities, Buddhist communities, Hindu communities, and so on and so forth. And so that's an exciting project, and I'm glad you're able to attend as part of it today. Let me share with you, inshallah, kind of our goal for this particular training and what we're going to be focusing on. I'll touch base briefly on what it means to talk about Muslim communities. There's quite a bit of diversity, so I'm going to share a little bit about that. And then I'll dive right into this Islamic perspective when we think about health, particularly mental health, wellness, and illness and treatment. I'll also integrate a little bit of what it means to bring in spiritual experiences and how do you distinguish that from psychopathology in the case of mental health. And then we will talk a little bit about, in a clinical setting, how it is you bring in the concept of what we call the cultural formulation and how to do this for the Muslim patient, inshallah. And so with that, we'll go ahead and start. Bismillah ar-Rahman ar-Rahim. Let me share with you a little bit about what I mean when I say the Muslim diaspora. Here in the United States, we know that Muslims are really a small percentage. The research shows that it's about 1% of the overall US population. But across the world, we're talking about about a fourth of the world's population. It's a good number, a good chunk of the world's population. And what that means is that the diversity of all the races and all the ethnicities and all the social economic levels, educational levels within the Muslim community, there really isn't just one community. Often I will use the term Muslim communities for that reason. And here in America, it's really important to always touch on, when we think about who are really the majority. Probably the more visible majority tends to be South Asian Muslims or even Middle Eastern Muslims, but actually the larger percentage, although no one group has the main percentage, but the largest of all here in the United States of American Muslims are actually African American and Black identified Muslims. And that's important because there is a long history related to Muslims and America, coming first with the first generations that came through as slaves in this country, and what that means over the years and centuries in terms of, how much of that Islamic identity was retained and how much of it was lost and potentially refound for some. Also, we talk about immigration and different waves of immigration that have come through, some from very early on, 50s and 60s, but the majority we're talking about in the 80s and 90s. And what that means for first generation Muslims, second generation Muslims, sandwich generation, which basically means, which maybe actually make up a lot of the folks potentially here right now, who are, a generation in which they are in between. They either were born overseas, but mostly raised here, or they were folks who spent some years of their childhood overseas and then the rest here. And so they are both Americanized and also retaining part of their cultural heritage. And for many, have children who are now considering themselves, who were born and raised in the US, and acculturation or issues related to generational gaps start to emerge. So we will touch on a little bit of that as well. And very important when we talk about Muslims is making sure that we also, just like the racial and ethnic diversity we also have a varying degrees of religiosity. And this is really important. There are those who are every part of this spectrum, from those who believe and are very observant of all the tenets of Islam. They practice these tenets on a daily basis, to the other end of the spectrum of people who say, my family was Muslim, or, I was born into a Muslim family, but I don't practice. And so there's everywhere in between. With that very large diversity, now comes the question that I have for all of you here. And I would love for you to interact with me somewhat and really use the chat box if you don't mind. And I'm going to open mine up so I can see your responses. But I would love to hear your thoughts. What comes to mind when you hear the term spiritually integrated care? I think it'd be great to hear from the audience here to see what comes to mind, given that we are talking about the American Muslim population. And what does this mean to have spiritually integrated care? I'll give you a moment to think about that. Yeah, excellent. Wonderful responses. Kind of thinking about, what does this mean? What kind of questions come up? There are questions, you're absolutely right, things related to decisions of end of life care, for example. Are there other places in which spirituality or religion shows up in care related to religion or spirituality? There's a comment here that talks about the ability to connect with my faith and teachings and beliefs. Strategies that aid in mental health, absolutely. Those are absolutely right and accurate. MashaAllah, thank you for sharing that. Excellent. Yes, acknowledging the importance of spirituality as dimensions of care, absolutely. What do patients understand in terms of their spirituality that influence their health, healing, and decision-making? Very nice. Also, questions related to creating treatment plans and strategies that are God-conscious. Very nice. Strengthening our beliefs, which in turn helps our mental health. Excellent, excellent. Exactly. And so when we think about this a little bit more, the term called spiritually integrated care is really an approach that helps us address the spirituality of the patient or the client that we're working with. We use the word client for those who are clinicians in therapy, who are doing therapy. So often our marriage family therapists, our licensed professional counselors, our social workers will use the term client. Often physicians, MDs will use patient. And in either case, it's really, how do you address spirituality? And I want to tell you that this is not something new or something specific to Muslims. In fact, there's an entire literature about this and other domains of study that actually look at this very thing. And some really excellent research studies by some of my own mentors in the field, Dr. Harold Koenig, for example, and Kenneth Pargament, and some others who've done some really great work on, some of the best outcomes for patients who are from faith communities, is that you integrate their religious and spiritual healing practices into the actual healing prescriptions or diagnoses that you are working on. And that actually means that they might fare much better than if you don't. So for Muslims, now we turn our attention to Muslims, some of the research historically, I would say in the last 20 years, and then some of the research that we repeated more recently, shows that Muslims are more likely to underutilize mental health care services and are less likely to seek out that support from mental health clinicians compared to other religious groups. And you might ask why. And the research we've done on this shows that the reason, often the most common reason for this, is that people want a spiritually integrated care model. They're looking for either therapists, psychiatrists, psychologists who are able to bring in Islam into the story and who won't judge their religion. Furthermore, especially if we're talking about parents of children, I often hear, and in the research we find this come up often too, that parents are worried. What if I put my child with a therapist who is not of my same faith background, and they may quote, and this is a term I hear often, brainwash that child, or have them think differently aligned than what I think or how I've raised them. And this is often a concern that people have quite often. And it's not unfounded. It actually has its place. And there's certainly people have had some very poor outcomes in therapy that was not well aligned and not very well culturally attuned. I would like to think that most therapists who are trained in the field have a certain level of cultural competence or cultural congruence, but it's true that it's not everybody. And so part of the training that I do here at Stanford with our psychiatry residents and with our psychology trainees is actually, I have two courses that I teach. One is called Culture and Religion in Psychiatry for the residents, and another one called Diversity and Culture for our psychologists. And in those courses, we talk quite a bit about what does it mean to bring in questions and discussions related to religion and faith in working with patients. Because I would hope that if they ever had a Muslim patient one day, that they would think back to some of our case studies and discussions and really take a pause and realize that bringing spirituality into the story might actually be very important for someone who comes from a faith-centered tradition, a God-centered tradition, in which it would be very hard to quote, and this is a line you find in the literature, quote, check God at the door, right, of therapy. And so we don't want that. We want to make sure that people who come through, who have coping mechanisms where they rely on God and rely on religion and actually heal better in that way, are able to bring that into their healing process and not have to feel that they have to leave a part of themselves out at the door, right? And so let's talk about this in more details. And let me ask you another question here. In an Islamic context, how do we understand illness? What are some of your explanatory models that either you have, or for those of you physicians here, how is it that you have explained illness to your patients or heard your patients explain why it is they have whatever condition it is that they have? How do you understand this from an Islamic context? Yeah, I agree. I agree. Some people will describe this as a test. They'll point to whatever diagnosis they have and say, this is a test from God. Others think to be a punishment, right? Absolutely. Some others are thinking of it as you're mentioning here, a trial. Absolutely. Some people say that it's a sign that Allah loves you. Very nice answers. Yep. Yeah, I would say that these are all very, very common answers I also hear and that we find in our research as well. So let's talk about this from an Islamic perspective. And you'll see here at the bottom of the screen that there's different modalities of thinking. One could be a very biological explanation, right? Where a person says, I have this depression because the neurotransmitters in my brain are not synapsing the way they should, right? Or someone might say, it's a hormonal issue and talk from a very biological perspective. They might point to genetics and say, this runs in my family, something like that. Or they might explain it to you from an environmental perspective, as in to say, I was fine up until the point that the country where I lived ended up having a war happen. And therefore I felt a sense of trauma after that war. And so it's an environmental, as in to say, it wasn't something genetic loading, let's say, but it was something they experienced around them. They had some level of trauma that happened, small or big. Other people might have a spiritual explanation, like some of the ones you've given me in the chat box here already, a trial and tribulation from God, a test, a reminder, an expiation of sins, right? And others yet might have what we call a supernatural explanation. Can you all think of some supernatural explanations that you've heard, particularly in mental health, but really could be any health condition? I wonder what's come up for all of you. Yeah, definitely. Jinn possession is probably at the very top of that list. Yes, evil eye, and absolutely magic. Absolutely. These three, I would say, are probably the most common. And interestingly, they are not specific only to Muslims. They're not unique only to the Muslim community. In fact, you have people talk about this concept of the evil eye or hexing, right? That people might say in other cultures as well. Or the concept of jinn possession. This is not unique to Muslims, right? There's all kinds of even popular movies around exorcisms and such, right, that you find in other faith traditions, particularly the Christian faith tradition as well. Or magic, black magic, right? This concept of sihr, someone has cursed them. And interestingly, in the Muslim perspective, all three of these are dealt with in our Sharia, in the Islamic sciences. They're dealt with in the Hadith or in the Quran directly. And what we're taught by them is that they could be explanatory models, right? They could be things, but we do not limit everything to just them. So you see people kind of take where you can have this very multifactorial understanding, particularly mental illness. There's so many different ways of thinking of why a person may have a mental illness. Sometimes it's a combination of genetic, environmental, spiritual, right? It could be any one of these. And when it comes to the supernatural, sometimes people say, no, it's just because they're possessed. The psychosis they have is a jinn possession and only a jinn possession. And so sometimes there's a negotiation that we do as a physician. I often find myself saying to patients, particularly when it comes to things like psychosis or mania, I often find myself saying, look, I'm not a jinn doctor. I'm a psychiatrist. And so I can't tell you whether your family member has a jinn possession. However, if you wish to speak to the sheikh, a sheikh who is able to either tell you or read some Quran for that person, a ruqya, you're welcome to do so alongside and in parallel with, right, in tandem with the care and support, as long as we can come to an agreement. The reason I do that, for all the clinicians who are wondering about this, I find that if you shut it down completely, you break rapport with that patient. And they're coming again with their explanatory model, right? This is their explanatory model of illness, of what's happening. And for us as clinicians, as physicians, to kind of shut it down completely actually does not help. It builds resentment, and it also breaks trust. And so instead, what I find myself saying is very honest and saying, look, I understand that these aspects, whether it's evil eye or magic or jinn, are mentioned in our Islamic tradition, but I'm also not an expert in these things. And so if you want to work alongside of me, let's handshake on it, that you will continue to work with me as I continue to work with you. And I don't mind bringing in Sheikh so-and-so into the equation if that's going to comfort you in some way. Also, reading Quran or Ruqya is not something that's terribly problematic. It's actually part of our sunnah. It's where it becomes problematic is if somebody stops taking the medication, isn't willing to engage in the treatment, and is really focused on only this thing. At that point, it becomes very hard, I'm sure as you can agree with me, to treat them, at least from a medical perspective. I share with you these different buckets of explanatory models because they are the most common of health models. And I share with you specifically the hadith that you see here on the slide that says, the hadith of the Prophet ﷺ that says that there is no disease that Allah has sent down except that He's sent down its treatment. I find myself using this hadith very, often, probably once a day, if not more, in my clinical practice, very often. And in my case, I use it for mental health, but you can really use this for any health condition. And it's very important. I mean, let's think for a moment as a group here. It's in very recent memory of COVID-19, right? When the pandemic first broke out and COVID first happened, we all remember those first few months and how, into that first year that was very difficult, right? Nobody knew how to treat this. Nobody knew exactly what was happening. People were passing away and dying. We were all in isolation and lockdown. The whole world had changed completely. And I would often hear people in the Muslim circles say this hadith, that if Allah has sent down an illness, even a brand new illness like COVID-19, we didn't know what to do with it yet, that He also has promised to send down its treatment. And these treatments don't fall from the sky necessarily. They take a lot of work and experimentation and scientific progress and moving it forward. And this is the same spirit in which the early Muslims who first received this hadith, right, the saying from the Prophet Muhammad sallallahu alaihi wasallam, that inspired an incredible, incredible Islamic legacy on medicine, right? Advancements in medicine and science had a lot to do with hadiths just like this, right? There's several in the hadith body of literature. This is one of them, but it's powerful. And it really allowed the early scientists and physicians of the Muslim history to say, yeah, if we see an illness in front of us, we've got to figure out what to do with it. And so they really worked hard, and they didn't discriminate between physical illnesses and mental illnesses, which is why there's such a beautiful and amazing legacy of mental health treatment in the Muslim lands and in Muslim heritage that you don't find in parallel civilizations quite at that depth. And so I share that with you because I share this with my patients very often, and it helps them. I find that it helps them help reframe some of the ways they're looking at it. On this slide, you're going to see that some of the things you've already mentioned to me, like what are the spiritual explanations? And some of these are perfectly fine. I might even agree with my patient and say, look, it could very well be this is a mercy from Allah subhanahu wa ta'ala. And I don't know if this is a punishment or a reminder for you, or a test or a trial. Only Allah knows. However, if this is how you are understanding this to be, I want to make sure you're also making room for the other explanatory models beyond just the spiritual or the supernatural. And this is where then I have the opportunity to explain to them about the biological, genetic, other aspects, right? Environmental causes of illness, mental illness in particular. And it becomes much more of a rich discussion. And often they're able to think and sit back and say, oh, wow, I think I really kind of pigeonholed right to spiritual causes and didn't give room to really think about the other aspects. Because in our tradition as Muslims, we've never really had this fallout between science and religion. That's not our history. It's true of the Christian history, but it's not true of Muslim history. That there wasn't this major fallout between the church and science. Whereas for us, it was always quite integrated, and that helps. I think that really helps this folks be able to sit back and think about this, even if it takes them a little bit more time to be convinced to move to the next step, which often would be, for example, medications, right? Or accepting a diagnosis. So I just wanted to make sure that we talked about each of these buckets, these different models of understanding. And as a clinician, as a physician, when you sit back and you think about where your patient is coming from, to be very careful not to jump straight to just the biological model, to make room for the other aspects too. This builds rapport, and it also builds trust. And you're speaking a more common language with a patient who's coming from a faith tradition. These boxes here are, yes, we're talking about the Muslim group, but really they work even for patients that I have from other faith traditions, particularly the Abrahamic faiths. This often works quite well. Now, in addition to this, I also wanted to mention how in Islam, there's an Islamic lens with which we look at health and illness. And so I wanted to share with you some of these as well. The first here is really the importance of prevention. The way I frame things, such as, for example, in our mental health status exam, right on intake, right, that very first time I meet a new patient, there's a whole host of questions I have to ask. And sometimes it gets a little bit prickly to ask certain questions to Muslim patients, because on one hand, I can't assume one way or another how practicing or not practicing a patient is. the Islamic tenets, even if they tell me they're Muslim or they have a Muslim sounding name or they're dressed in a way that makes them look like they are a Muslim, etc. At the same time, it's really important that I elicit this information and I don't think that, oh, just because they're Muslim, they don't drink, for example, or use drugs. And when I ask these questions on intake, I often will find myself saying things like, I have to ask some pretty standard questions now that I ask of all patients. And if it doesn't apply to you, just simply say no. But we should talk about these. And when patients push back a little bit, if they do push back, I'll say, look, in Islam, we often think about these. I think about Islam and all of its rulings as very preventative in nature. And for those of you who are interested and invested in preventative medicine, Islam works really well in this domain. So you see, anything that is harmful substance to the body or the mind is prohibited. We know that one person can drink a sip of alcohol and be fine, and the next person right next to them may take a sip of alcohol, their first sip of alcohol, and become an alcoholic for life. And there's really no way to tell until it happens. So Islam comes around and just says, no alcohol altogether, 0, right? Same with drugs. And this concept of avoiding harmful substances and taking care of one's mind and body is such a core tenet of Islam. And the way I explain it is in the Maqasid al-Sharia, which is basically the foundational principles of Islam, in which all the rulings, the fiqh, is derived from. One of the core ones is preservation of the intellect, preservation of the body, preservation of the lineage, preservation of wealth, right? Preservation of health, right? These are core maqasid or principles of Islam. And so then you can see how so many of the rules then are built upon that. And that's why there's a 0 tolerance policy for things like alcohol and drugs. This is also a route I sometimes with my very religious patients who are very invested in Islam and very suspicious about anything related to the medical background, particularly psychiatric. I often come to the conversation about psychiatric treatment from that door, where I'm able to share with them, look, if we're trying to preserve the intellect, and that is one of the maqasid al-Sharia, one of the foundational principles of Islam that you and I can agree on, then if a person's intellect is not well, if they are not doing well, then it is incumbent on us to make sure that we seek out the kind of treatments that help them do well. And I realize that there is shame, stigma, cultural taboos, and other things that we need to, barriers, hurdles that we need to address. But from this door, at least it starts to open a conversation that we're speaking the same language. And from there, I could start education around, what we call psychoeducation, around psychiatric conditions. And this may work again with other health conditions. Today, we're focused on psychiatry. Also, this concept that we talked about earlier about religiously integrated care, I share with them that if they wanted this, and I don't ever assume that anyone who comes through my door wants Islamically integrated psychotherapy, they may not at all. But for those who do, I reassure them that now we have actual training that helps clinicians learn how to do Islamically or spiritually integrated care. There's a book that I helped co-edit called Introducing Clinical Islamic Concepts in Professional Mental Health Care. And it's basically the TIP model, the Traditionally Islamically Integrated Psychotherapy, TIIP, which is a book that you can find, inshallah, and read kind of through. But also there are trainings. There's actually a 4-level training called the TIP training, the TIIP training, in which you're able to learn how to do spiritually integrated care as a clinician, particularly for those who are in psychiatry and psychology for therapy. But honestly, I would say any clinician can benefit from this way, especially if you're in any of the fields in which there's a counseling aspect to the work that you're doing. So I wanted to share with you a little bit about that. And then sometimes also it's helpful to bring in Islamic concepts if the patients are open and wanting that. So they may say things like, well, doc, shouldn't I have sabr? Shouldn't I have patience with what God has sent me? And I'm willing to, this is where I kind of take the time to really hear them out. Yes, of course, sabr, patience is required by us as Muslims, but does sabr mean that you're just going to sit back and just let fate take its course with no treatment? Or does sabr mean that you tie your camel, right, and then depend on God and be patient with the outcome? And so we have this whole conversation sometimes back and forth, and it's not a preaching model in any way, and it's not one that's trying to convert somebody or make them think differently than what they are. But if they're coming to me and identifying as, as part of our intake process, it's when I ask questions like, what are your support systems, and if they bring up Islam, religion, Allah, my masjid, my sheikh, my community, and anything related to those aspects, and I say, okay, if those aspects are healing to you and they help in your support system, then let's also frame illness and treatment from that perspective. And often the ahadith that I mentioned to you, the one earlier about with every illness comes a cure, and the second one that I just mentioned here of tie your camel, then depend on Allah, ya'qilha wa tawakkal, right? That whole story becomes really important for patients to say, look, if Allah has sent us an illness and He sent the cure, and modern medicine has now the gold standard of whatever illness you were talking about here is X, Y, and Z treatment. I'll give you the example of OCD, obsessive compulsive disorder. My caseload has a lot of OCD in it, and I work quite a bit with this in both therapy and in medications. And so most all of my Muslim patients refuse medication right off the bat. They nope, don't want it. And so what I'll say to them is as a psychiatrist, I have to tell you, do my due diligence and tell you the gold standard treatment. And the gold standard treatment is a combination between both medications and therapy. And the therapy is a particular type of therapy, ERP, or a type of exposure, a gradual exposure therapy. And so often people will opt right for the therapy. And I'll say, fine, we'll start with therapy, with an agreement that after a few weeks or even a few months into this treatment, if you're not improving significantly, that you and I have agreed that we'll come back and revisit the medication story. Do your part, tie your camel, and then depend on God, right? And often this works. And oftentimes I find my patients coming back after a few weeks and going, I am doing my best with this therapy and I'm still not getting this much better. And I say, yeah, that's why the gold treatment is actually a combo treatment. And they'll say, okay, I think I'm ready for medications now. And so sometimes going at their pace and explaining to them and being quite transparent with what the treatment measures are, and sometimes going slower than some of my other colleagues here, for example, knowing that this is how I'll eventually get to them to get to a place of not completely quitting and running away because I'm insisting on medications off the bat. And also, at the other hand, not kind of prolonging, right, their treatment by just being able to build more trust and rapport. And it might just take a little bit longer, but this integrative model tends to work much better, I think, with patients, Muslim patients, and those from faith traditions. And I would love to hear your responses about this as well. Now, speaking of barriers, there's a couple of barriers here to also mention, particularly with mental health. I find that people have quite a number of concerns related to what if the views of that psychologist, that therapist, that psychiatrist is different or in conflict with my views, whether they be the views I grew up culturally or from my faith directly. And they're not wrong. There is definitely a reason why we have built out an entire field called Islamic psychology, because Western psychology is not God-centric, and it sometimes even demeans religion and God. And so for people from faith traditions, and again, Muslims aren't unique here. The Christian community is doing the same. You find Jewish community doing the same. Other communities are doing the same, where they're really bringing in the spiritual model into the story. And for those of you in an academic setting, or really any hospital setting, I'm sure you've noticed that there's quite a bit of today in these last 5 years, you've noticed DEI work or diversity, equity, inclusion work. And one of the interesting things is that this push or this movement about intersectionality, bringing all your identities into the space, your workspace and your healing space has been really interesting, because for us as Muslims, this is probably one of the main doors I'm finding now, being able to bring the topic of spirituality and religion. I've been doing this research for a long time, well before all the DEI work has come to fruition. But it's interesting, with the DEI work, I have found the doors more open, because the movement is this. It's basically saying, bring your whole self into care. Bring your whole self into therapy. bring your whole self, all your identities into care. And I often say, look, identities are not just racial, ethnic, socioeconomic, sexual, and so on. It could also be for people from faith communities, their religion. And this is where people pause and go, oh, that's right. And the door starts to open up more for this kind of conversation. And where there had been a tension between Western psychology and Islamic psychology, now there's more of an open discussion of being able to say, look, there are other culturally adapted psychologies or therapies or treatments. And today's, as I teach today, the psychiatrists and psychologists in training today, the up and coming generation, they are all about this. They are very interested in these more culturally attuned therapies, realizing that so much of our care has been very Eurocentric, white centric, and has been not always healing for communities of color and communities that are minority or marginalized communities. So it's interesting. It's definitely a different era than we have been in before. And I would say embrace the part that allows you to bring in the spiritually integrated care for faith communities as the store is open and continue to be cracked open more and more. Other barriers of seeking treatment for Muslim patients in particular is, again, we talked about spiritual lens, where people will say this psychopathology, this depression or anxiety that I'm feeling must be an issue with my character or an issue of a lack of faith. Maybe if I just prayed more or made more dua, or maybe if I was a better Muslim, this would not happen to me. And this is where we do a lot of education to explain to people that multifactorial model we talked about at the beginning, and how while there could be some aspect that is spiritually connected, it is not the only explanation. And as a result, prayer alone isn't going to treat something that is a genetically loaded illness that's been running in your family for generations, right? And this is where building up that trust and also building up knowledge, just lack of awareness and knowledge on these topics could be quite harmful to our communities. And so I'm very happy for all of you to hear, because I think you're going to be part of the solution, inshallah. Which leads me now to my discussion on the checklist. When we work with Muslim patients, this is what I meant by when you do the intake, there are aspects to really pay attention to. So some of those aspects, let's go through them together, inshallah. So you may see here that some of the discussions hang on. I went backwards 1 minute here. There we go. All right. Some of these aspects is what we call the cultural formulation in the DSM, which is looking at a patient's cultural identity, looking at their cultural explanation of the symptoms. Both of these we've covered in the earlier slides. Also, looking at the cultural components of their psychosocial environment. And what I mean by that is one good example I say to people here in my office here. I'm sitting here in my office at Stanford today, and it's not a very big space necessarily. It's enough for a few chairs. But when my patients come in from Muslim backgrounds or really other cultural backgrounds too, I find that there are this Western model of it's patient and doctor, and it's just back and forth. Okay. And so you say the diagnosis and you say what the treatments are, and the patient nods their head and says, okay, doc, I'll go ahead and do that. And then you realize that they're not doing this. And week after week, they're not actually following the prescription or following what it is you're hoping they're going to follow. And you wonder why. It could be because the model is not an individualistic model in that way. It very well could be a more collectivist model, which essentially means that there are other stakeholders involved. So it is not uncommon. It's quite common for me to be running up and down the hallway here, collecting chairs from whatever open spaces have chairs and pulling them into this office space, because inside comes my patient, their spouse, their parents, maybe a grandparent, maybe a child. Right? There might be multiple generations of people coming into my room because they are all stakeholders together invested in this patient's care. And if it was just my patient, and of course we only do this with the patient's permission, but if it was just my patient, they could be nodding the whole time I'm talking. Yes, doc. Sure, doc. Okay, doc. No problem, doc. And then do nothing of what I asked them to do. And this is where I teach people to remember, there are invisible stakeholders in the room. So it's better for you to actually incorporate them into the care. If they would like to come in person, great. If they'd like to have one family session, I usually do like at least one family session with the permission, of course, of my patient, just to make sure that everyone's on the same page. Because when I come to prescribe whatever treatment I'm prescribing, I want to make sure that whoever are the stakeholders, that they are on the same page and in agreement. And it just takes a little more work than the average person who it's very much a kind of a linear back and forth individualistic relationship between doctor and patient. But that's not really true of so many of our cultures, is it? Right. So that's what they mean by these cultural components of the psychosocial environment. Also, this relationship between individual and clinicians. I have learned many times that there are cultures in which there is more deference to authority. So as a physician, I'm holding a certain level of authority, and a person might just nod, but not agree with a single thing I'm saying. And so really understanding what that means. So it might be much more of a hierarchical versus a parallel relationship, and really trying to understand where that patient is coming from and how to make sure the message is getting across and adhered to. And then the cultural elements of disease manifestation. And this is where I try to assess, do they have the language to explain what is happening? What I mean by that is, are they able to use comfortably language like depression and anxiety, trauma, etc.? Or is it more manifesting somatically, right? My stomach hurts, my head hurts, my back hurts, terms that are much safer to use because they're not going to be judged by their family and community by saying them. But in reality, they are masked by mental health conditions. And so this is where I assess for that and try to figure out how to best help them based on wherever I meet them, wherever on the road they are, right, in this process. And I encourage you to do the same as well. And in terms of looking now specifically on intake on the spiritual assessment as a clinician, when you're doing what we call the religiosity assessment, we said there's a whole spectrum of people who identify as Muslims. These are questions that I have found to be very useful for patients to really ask questions like, for varying degrees of identification with a religion, to ask in this very non-judgmental manner, and to really be curious about various aspects that might help you understand their religiosity. Things like, what is your childhood experience with religion? So, for example, it's really helpful for me to know, did a person grow up going to the masjid? Or did their family, or did they have a fallout, right? Did they experience Islamophobia at some point? Or did they ever have a period of their life where they did a religious exploration? They weren't too sure about Islam, and so they were kind of exploring a bit more, or even if they were sure about it, they were just curious about other faiths. And is there stress or pressure from the family? How involved is the family in their decision-making process, in their guilt, and in their worries, stress that they're carrying, right? These are questions that really help me elicit what's going to help and what's not. So what I might ask are questions like this. Do you consider yourself a religious person? And if the answer is no, we just move on. We don't have to stop any further. But if they say yes, then I might ask further questions like, how do your religious beliefs affect your day-to-day life? What I'm hoping to hear from them there is prayer part of the story? Are some of their struggles where to figure out how to pray? I'm on campus here, and so I work with a lot of students. And one of the biggest stressors for them is, how do I leave in the middle of class to go pray? Or how do I negotiate with my professor when it's Eid, right? I need to take some time off, or I need an extension on a project or something, right? How do I negotiate my religious identity with my life, whether it's at work or at school? I might also ask questions like, are you involved in religious groups in your community? And if so, are they a source of support or distress? This helps me figure out where they are in the spectrum of religiosity. And depending on what they say, I might then offer as part of my solutions, could a spiritually integrated care model help them and work for them versus not? Personally, for me, when I call a patient back from the waiting room, I'm dressed as I am dressed, so it's clear where I'm at as a hijab-wearing Muslim woman. But for my patient, despite what they're wearing or any identifiers or lack thereof, I don't assume anything. So I really just call their name and have them come back to the room with me. And often I've had Muslim patients call me out and say, Dr. Awaad, aren't you a practicing Muslim? And I say, yes, why? And they say, you didn't say salam. They get really upset with me. You didn't say assalamu alaikum. And I explained to them, even the salam, in my case, this is a personal decision I've made, is I don't know. And I don't want to assume. I have no idea what your level of practice is before I have met you. And so at this point, I just call your name and welcome you into the room, and then we will have a further conversation. And they're like, oh, okay. And when once I know that they prefer for me to say salam, I'll more than happily say salam to them next time I call them back into the room, right? But these kind of small gestures are really important, especially if you're working with someone who is not so interested in this religious perspective and may be worried about you and your religious practice as well. Will you judge them, and so on and so forth. Now, as we come to a close here, the last part of this particular training is a series of cases that I would like to go through with you, because we've talked a lot about theory. And from theory, I'd like to take it into practice. And so here is where I'd like you to use your chat box again. And we're going to talk a little bit here about three main themes. There's a theme here of devotion versus deprivation, religious observance versus scrupulosity, mysticism versus psychosis. And this is where we have to figure out what level for mental health here, what aspect of this is psychiatric, and which psychopathology, and which of it, where do you draw the line for spiritual experiences, right? Because we don't want to pathologize everything, nor can we say that everything is a spiritual experience. So where do you draw that line? So I'm going to share with you here the case of Inaya and Maryam. We'll read it together, and I would love for you to share with me your insight. And the question here is to fast or not to fast. So we just passed the month of Ramadan. So let's assume that Inaya and Maryam are both your patients. And Inaya comes in, and she's an 18-year-old female with a history of anorexia nervosa, restricting type, with a BMI of 15. And she's coming for follow-up in the outpatient clinic. Several months ago, she was admitted to the medicine floor after passing out and found to have hypokalemia, prolonged QT, and SMA syndrome. She required close monitoring for refeeding syndrome, and then she was discharged 3 weeks later from the medicine floor straight to the inpatient unit for eating disorders. She stayed there for 2 months, and then she was discharged 1 week ago to go back home. You have Maryam, who's another patient of yours, who comes in for her, she's a 33-year-old female, and she's presenting for her annual checkup in your outpatient clinic. The chart review reveals that she has a history of anorexia nervosa purging type that started at the age of 15 and improved with symptoms in intensive outpatient treatment. She has not had any purging episodes since her senior year of high school at the age of 18. She has no other medical conditions or sequelae related to disordered eating. Her BMI is 20, blood pressure is 115/75, and heart rate is 70, all within normal limits. So my question to you is, you have Inaya and you have Maryam. They're both ask you the same question. It's Ramadan. Do I fast or do I not fast? What are your answers for both of your patients? What are your thoughts? All right, we have a vote here that says no fasting for Inaya, but Maryam can fast. We have another vote that says no to both. Another vote for no for Inaya and yes to Maryam. For Inaya, someone else says they're concerned. Yeah, okay. Someone else says that Maryam should fast because she's healthy and stable, not too sure about Inaya. Some say, someone is saying that Inaya is a maybe. Okay, so we have a mixed bag here, right? We have a mixed bag. And so, Maryam, you're more inclined, okay, and open to the conversation. Very good. Thanks, guys. I appreciate this. I appreciate your partaking in this. And you can see here how there's a range. You know, someone says yes to both, someone says no to both, mashallah. And so you can see how there's a range, subhanAllah, a range of opinions amongst us clinicians about this. And this is exactly what patients experience. Exactly what patients experience. I can tell you from having patients like Inaya and Maryam, one of their biggest frustrations is when they come to a physician to ask about something that's more spiritually or religiously connected. by the way, whether this is a Muslim physician or a non-Muslim physician, maybe experiencing it maybe slightly more with non-Muslim physicians, but really both. And they'll say, they're just not hearing me out. They shut it down completely. And the answer is immediately no, all the way through. And then I reflect on, well, why is the answer immediately no? For someone like Maryam, who has had over 15 years of no symptoms, right? She has a history historically of this. My next question for Maryam would be, so in the last 15 years, what have you been doing? And if she says, I've been fasting every Ramadan. And so I might ask, well, how have you been doing in the last 15 years before I've gotten to meet you at the age of 33? And if she says, great, I've had a wonderful, I'm all stable, never had a relapse, doing great for 15 years, right? That's a lot more indication for me. And probably more comfort to say, like many of you were saying, probably yes to Maryam, assuming that everything else kind of checks out in her story. The problem with folks like Maryam is even with a history of a remote history, physicians, we fear the unknown. We don't know the unknown. And so we also fear what we haven't been directly trained in. And because historically we've never really been trained on religious and spiritual aspects of care, it's just an immediate no for so many doctors. I one day a week, I'm embedded in an OB clinic. I do women's mental health as one of my specialties. And so embedded within an OB clinic as the psychiatrist there, I have the same thing happen with pregnant patients all the time. The immediate, when Ramadan comes up, the immediate answer is always no for most OBs, not paying attention to, what stage of the pregnancy is she in? How healthy is she in that pregnancy? How many other pregnancies has she had and probably fasted just fine, right? Even though every pregnancy is different, it's almost like an immediate shutdown without really any real discussion. And this is where I caution you to not go immediately to that point. We have a really wonderful paper actually published in the Lancet on recommendations for physicians working with patients that have psychiatric conditions and fasting in Ramadan. And I'm happy towards the end here, I'll put a link to some of the papers we've published on guidelines of what to do. And you'll see this guideline that we've created related to a patient like Maryam. Now, Inaya, on the other hand, I agree with so many of you who exactly have this concern, considering how recent her and how acute her issues had been. I too would be quite concerned. And I would talk with her and see where she's at. And if she's like, no, I really have to fast, doc, right? I'd have a whole conversation with her about, have you brought in your imam, your sheikh, somebody who's a religious scholar of your community to talk about alternatives to fasting? And is it about the fasting in and of itself? Because of course we worry about somebody masking their eating disorder with fasting. Or are there other issues? And for a lot of times, because eating disorders tend to be invisible, people can't tell by just looking at you that you have an eating disorder. But they can tell that you're not fasting. There's a lot of shame and people prodding and asking, why aren't you fasting? Right? That happens. And then there's all this extra explanation they have to say, and they don't want to say, I have an eating disorder, right? I'm exempt from fasting because they don't look sick, right? Necessarily. And they don't look like they have a broken limb or they're pregnant or some other reason why they may not be fasting. So there may be all these other societal, right, community-based shame and stigma that they're carrying, or feeling like they're not part of Ramadan because it's such a communal thing that if you're cut off from that community, there may be other ramifications that drive her into a deeper depression and more of an eating disorder. But safety first. And this is where I agree with you. Taking the time to really assess, where is the patient's mind about this? What is their conceptualization of illness? Why are they all bent out of shape about fasting or not fasting? Is really helpful in the treatment process. And yes, this all takes a little bit more time, absolutely. But usually the outcome is much better, right, than an immediate no, and more rapport. Even if the answer ends up being no anyway, the patient will have appreciated you thinking through and the transparency of some of the thinking process that allows them to say, well, at least that doc took some time to really care about why I'm thinking the way I'm thinking, right? So these are all aspects to think about. I hope this was useful to you. And so when we think about this, eating disorders, the recommendations definitely is, and please make note of this, case by case, right? This is what we say in our Lancet article as well. It's a case by case basis in which multiple different factors have to be taken into consideration: level of insight and capacity, risk and benefits, stages of illness, active, partial, or full remission, severity of the eating disorder, how recent was the hospitalization and active psychological consequences, and of course, what is the social support like for that patient? Now, I'm going to turn your attention, inshallah, to the next case. So we'll read this one together as well, and we'll kind of work on this together. Here we have Layla. Layla is a 30-year-old Palestinian American Muslim with anxiety, mostly related to matters of worship. She says that she typically spends up to 1 hour washing her face and limbs repeatedly before the 5 prayers due to her anxiety of not being in a proper state of cleanliness. At times, she even misses a prayer due to the compulsive need to wash her limbs again to make sure she had gotten it just right. And her anxiety would be alleviated for brief periods of time when she feels that she sufficiently washed her limbs, but then the cycle starts all over again with the next prayer. Sometimes, even during prayer, she notices obsessive fears would start back up again, causing her to lose concentration and causing her to make the prayer up. This repetitive cycle has become to interfere with her satisfaction that she used to get from prayer, as well as her functioning at her job and at home. And so, physicians, what is your diagnosis? What are we thinking is happening here? Yep, excellent. This one is fairly straightforward, in which we believe that it's likely OCD, obsessive compulsive disorder. We see many aspects here of obsessions and of compulsions. And if we did a further intake for her and kind of more deeper assessment, and maybe even administered something like the Y box, the Yale-Brown obsessive compulsive inventory, symptom inventory scale, we would find potentially that there's maybe other aspects, other things in her life beyond religious ritual practices that she probably has either patterned or repetitive behaviors as well, right? And OCD is a tricky illness. It is, and it's a difficult to treat illness, but it's very highly treatable. It just needs the patients to get through both the medications and the therapy, the exposure therapy that it requires. And for so many people, for so many of my patients, excuse me, with OCD, for so many of them, they really do worry about not doing well. Sorry about that. Needed to take a drink of water. So my patients with OCD often really are concerned about, well, my prayer isn't going to be accepted. And I hear physicians say, well, how am I going to have this conversation with them? Because I'm not there to judge their prayer, right? Like how is it that I'm meant to help them in this way? And this is where I would really recommend that if you are at a crossroads, sometimes it's actually very helpful to turn to somebody who is trained in the religious sciences, or even just you. The fact that you have knowledge of things like there are 5 daily prayers, right? And even knowledge like 1 wash in wudu is fard, right? Obligation. And washes number 2 and 3 are sunnah, and no more than 3 washes per limb, right? See, the Sharia puts for itself these boundaries in order to make sure we don't transgress them, right? And so in my ERP, in my therapy that I do with my OCD patients, if they're stuck on something like wudu or ghusl, the ritual, minor and major ritual purification washings, I'll put these positions in place. And sometimes I even say, no more than the 1. And they say, only 1? I say the 1 is the fund, right? But we'll break it down. We'll kind of do a gradual. If they're at 50, we'll go to 40, 30, 20, all the way to 3 washings or 1 washing, or maybe it's a certain amount of time. I'll say, how much time do you take? And I'll say 10 minutes. I say, oh no, we need to bring that down until I only give them, a matter of a few seconds or half a minute or something to do the washing of a limb. And the reason that's important, and it takes time, but the fact that you have some knowledge built in and you can point to a hadith potentially that refers to the rules of wudu is very helpful, right? Because you're able to actually help this patient. Or again, if you'd like to do what we call a religious consultation, where you bring in kind of a religious figure who that person trusts, who says, okay, Layla, you're only able to do 3 washings and no more than 3, right? And if that is helpful, it really makes a very big difference for the patients, because then they have rapport with you and they're willing to do this treatment, because it's a gradual, right? It takes weeks to do, or with a therapist who's going to do this therapy with them. And at the same time, you're able to get them to do better. I have, alhamdulillah, tabarakallah, I've had patients, women, I'm just thinking of certain patients in my mind women and men both, who have gotten to a point where they could not even leave the home. I mean, they couldn't even leave their bathroom for hours on end in a day. Because if they touch something, they have to wash it. If they touch that thing, they have to wash that thing. They touch, it's on and on and on, hours of their day, until, for example, eventually be able to exit the bathroom and do other things in their house, and eventually even exit the house and get all the way from spending hours of doing nothing in the day other than washing, literally, at a more extreme level, to completing a master's degree and getting a job. I mean, it's phenomenal, subhanAllah, when you're able to treat this very treatable illness, but it takes some time, right? And there is a religious cross-section here too. All right, folks. So with that, this concept of waswasa, right, which you find in the Islamic, often referenced in both the Quran and in the Hadith, of these whispers of shaitan, is what people tend to call them. But we'd say there's a normative level of whispers of shaitan, but then there's also waswas al-qahri, which is a pathological kind of whispering or rumination that actually impacts a person's daily functioning. And this is where, some of you may have known that I had published earlier on a 9th century scholar from Islam named Abu Zayd al-Balkhi, who, from my research, seems to be probably the first, if not one of the first, to really talk about OCD all the way back in the 9th century. Whereas for often, in the Western psychology, in our psychology and psychiatry classes that you and I have all taken, it'll, often talk about a 19th century person, right? A millennium of a difference. But we've always had quite an extensive, history related to psychiatry as Muslims in our Islamic heritage. And it's really wonderful for my patients, and I'm sure for many of yours, to realize that, and to realize that it was not just looked as, Balkhi didn't say, well, just go pray, or just say, A'udhu billahi minash shaitanir rajim, because it's shaitan. He said, bring in the religious aspects, say your dhikr, say your prayers, but also, and he literally described exposure therapy in the 9th century. Literally, he has it all laid out. It's the most amazing thing. You're welcome to read some of those papers as well, inshallah. It's fascinating. And thirdly, he said, and take medications. And that's the Islamic worldview, right? Where you bring in all three aspects, not just one or the other. Now, my last case for you as we wrap up is the case of Ahmed. And Ahmed is a 24-year-old Bangladeshi American male with a history of severe depression and self-harm. He presents with worsening auditory hallucinations of a loud male voice who tells him he's worthless. He's anhedonic, unmotivated, and has difficulty with his appetite and sleep. And when Ahmed's parents noticed these changes in him, they told him that they were very worried about a jinn possession. Once he started to hear the voice, Ahmed himself became fearful that he was possessed. He has since become increasingly paranoid of his surroundings, preoccupied in thinking of what could potentially happen to him in the future. If Ahmed was your patient, how would you advise him? What is your working diagnosis here, and how are you going to help him? All right, we have a couple of votes. Some folks are saying this might be schizophrenia. Wondering, are psychiatric medications the first step here? Someone wonders if it could be bipolar disorder, meds and therapy combination. Okay, all right. Anything else you might do for this patient? Any other thoughts on how to help him? Yeah, I agree. There's a vote here for Islamic scholar referral. See, when Ahmed and his parents come to you, and if you say, the first thing you say to them is, I think we're working with schizophrenia here, right? And I think that this requires some medications and therapy. And they say, but doctor, we think it's jinn, right? They're basically, talking in this direction, you're talking in that direction, right? Like, we are not yet on the same page at all. And so what do? Right? So you want to listen closely to what they came in saying. They came in saying they think it's jinn, even if you 100% don't agree with this, right? But the fact that they said jinn possession is actually where you'll need to start. And you could say something to the effect of, so I hear you, right? Say that you think that this is jinn possession, and you might ask them why, what's your proof? And they may list out a number of reasons why they think it's jinn possession, right? And be very careful not to shut it down immediately and say, oh, no, that's just, no, that's not real. Oh, no. Be very careful, even if you don't agree. The reason is they're sold on this, right? They're so sold on it that they've also convinced Ahmed, right? The parents have convinced Ahmed, and they're coming to you sure that that's what this is. And this is where I was sharing with you earlier that I often say to my patients, well, I'm not a jinn doctor. I'm a psychiatrist. So let me share with you from a psychiatric perspective what I think is happening. And if you would like, there are shuyukh, and I actually have a specific sheikh in our local community who said, who says that he learned from his father, from his grandfather, from so on, of how to read that ruqya. And the very interesting thing about that particular sheikh is he will, unlike most, actually, it's kind of rare to find someone like this. So I encourage you to figure out in your location, in your locale, who are your psychologically minded imams, right? And sheikhs. So this particular sheikh is very interesting because he'll say, let me read the Quran to the patient. He'll do that. And then he'll say, this patient, I'm able to give them some Quran. And this other patient, he'll say, nope, can't help them. I've reached my limit here. This is not what I can do. You need to go back to the psychiatrist, go back to Dr. Awaad, right? And that's really helpful, right? When we have this rapport of, I will send to Sheikh Ahmed and he'll send back to me, right? And I think that's a very useful kind of relationship. And so if you can find this, and there are psychologically minded imams every so often, pockets of them, if you will, in different communities. And it's helpful to identify them for your own patients. But you really do need to start where they are at. And so here, what I would say is it's really important to use their explanatory model. If their explanatory model is one of supernatural, and that's what they're just fixated on, right? When I say to them, I can't do this, but Sheikh Ahmed might help you, they're able to say, I realized the patient's name was Ahmed and our local sheikh was named Ahmed. So sorry for the confusion, but it just so happened that they're both Ahmed, right? But when I say to them, Sheikh Ahmed is able to, they got like a relief because I didn't shut them down, but I also didn't say this is, jinn possession. I said, you could talk to Sheikh Ahmed as well, but let's agree that you'll continue seeing me too. And usually that means that they'll come back the next week and continue or next couple of weeks, continue with their follow-up. And then in this dialogue back and forth, and especially if Sheikh Ahmed says, this is a psychiatric thing, I really can't help you, then even more reasons they'll say, but Sheikh Ahmed said this is not, he gave us some Quran to read for ourselves over our child, but we can't, he says he can't do anymore. I say, well, but I can. Let me try to help you here next, right? And this is where we start talking about psychotropic medications. That kind of psychoeducation, that inclusion of spiritual leaders is usually very beneficial for many patients. It doesn't work for everybody, certainly, but there is a pretty significant subset this becomes really important for. So with that, I'm just going to close here with a couple more considerations that you might want to think about, especially for inpatient. For those of you, I realize we talked a lot about outpatient care, but for inpatient care, whether it be aspects of hygiene, like physical and spiritual cleanliness. I think about our patients who need to take al-ghusl or shower, for example, and having that available to them. Prayer 5 times a day, and having either the ability to go to the local chapel or be able to just pray in their own rooms, modesty and privacy. Of course, every time I've delivered, it's been this whole negotiation of please don't have male residents or male nurses or male nurse techs, kind of coming into my room, please. It's often a negotiation. And so the more attuned the physician and the nursing staff could be to the Muslim patients, the better. Of course, dietary requirements as well is definitely important. And then understanding aspects of fasting, if it's a month or time of fasting, becomes very helpful to Muslim patients as well. And so with that, I would like and give some time really for us to have any questions or discussion. And before I completely close, I just wanted to share that if you wanted a longer discussion or more interested in this conversation, we were able to do an hour today, but I have about a 3 or 3.5 hour training more in depth that the American Psychiatric Association is sponsoring, free right now. As you know, usually CME credits are quite expensive, but this one is actually free to you, inshallah. And so please do access it. Again, we could put all these links for you, or I could have the folks over at IMANA send out a document with all the links that I mentioned that I would share with you today, inshallah. But this one gives you CME credits and is also free for a certain amount of time. So please do access it, inshallah. I don't know if anyone's going to be at the American Psychiatric Association this weekend. I will be there. I'm presenting on Saturday. It's actually here in San Francisco. So if anyone on the line happens to be coming to APA, please let me know. I'd be happy to meet up with you during the conference, inshallah. And so with that, I'm going to turn it over back to our folks over at IMANA. And here is some of my contact information, and both also at the lab and the nonprofit organization Maristan, which takes my research at the lab, the Muslim Mental Health and Islamic Psychology Lab, and transfers it over into educational trainings like this one, workshops, classes. We also have free monthly healing and learning circles that you can send your patients to, and yourselves, of course, pop-up healing sessions that happen with world crises that might happen. We just had one for Sudan and one for the earthquake in Turkey prior to that. And we'll continue with all of these healing circles, learning circles, a lot of education around psychology and mental health. And we also have a clinic in which we have active praxis for any patients that are in the state of California, where we're starting our Maristan. That's the kind of work we do here in the community. So you have the contact information for all three. And with that, we'll open up for questions if you have any, inshallah. Barakallahu fikum.
Jazakallah khair, Dr. Rania. This has been extremely enlightening. As you mentioned, there's a lack of training on spirituality when it comes to the clinical setting. And since many Muslims feel comfortable and prefer a Muslim mental health professional in many cases, many deal with these issues and really aren't sure how to address them. So Jazakallah khair, and thank you so much for sharing your insights, your professional experience. And I'm sure many of us would agree that we would love to hear you continue to speak on this topic as well. We do have a couple of questions that have come in, so we'll spend a couple minutes if you would allow us that. One question is, what if the patient has depression or anxiety or internal conflict from a spiritual identity crisis? Would a mental health professional be the first line of response, or would it be a religious leader? Are mental health professionals trained to help the patient seek or develop a relationship with their faith, or do they often blame the faith for shaming them? So it looks like this is referring to a spiritual identity crisis that has been a link to their depression. So how would you address this?
Yeah, this is a wonderful question. I really appreciate the question. And it's true. Like, what do you do exactly in terms of, first, second, and third line of response? And I think we touched on some of this over the course of the training. And I would say it really depends where the patient is at. Who are they willing to listen to first? And so if it is the imam, again, this is where I really request that you try to figure out who's psychologically minded. I can probably list, wonderful spiritual and religious leaders in our community, but I probably would only refer to maybe 2 or 3, if I'm going to be very honest, right? Because they are more in tune, I think, with mental health, and won't say things to them like, just go pray, right? They'll actually say, actually, I think you need to go to Maristan, or something to that effect. And so, figuring out who those folks may be. Now, what I do tell the people that I'm training, though, my psychiatry residents and psychology trainees, I'll say to them, please do not speak out of turn. Everyone really does need to stay in their own lane, as in to say, if you feel this is above your head and you really don't know what to do, please call for, in the field, they call it a cultural consultation. So you can call it a cultural consultation or a religious consultation, but please reach out to folks who can actually help and assist. So who goes first versus second, to me, isn't quite as important as whoever that first line person is. They're able to actually say, let me help you get to the level of care you need, right? I think that's what's the most important. A lot of the trainings we do at Maristan, we have a very popular one you might be hearing about on suicide, which is a very difficult topic. It's the taboo within the taboo of mental health. And we have this full day, 8-hour certification training for imams and other Muslim community leaders on suicide. And the reason we decided to do this is exactly for the question here. We were just finding a lot of people finding it unsafe or just unable, or they'd find it shameful, or they'd be shamed or judged if they were to come and say that they wanted to end their life. And people would say, haram, no, as opposed to really trying to figure out that this is probably a red flag and a call for help, and that they needed higher level care than what an imam can offer. And or if they went to a mental health professional and the person is dealing with a lot of spiritual struggles and they're trying to just give medications, it may not be solving the angst that's coming kind of at a deeper psychological level. So our work is very much one that bridges kind of the up-to-date kind of scientific medical knowledge with the Sharia Islamic understandings, especially when these more complex and stickier issues. So anyhow, I just please know about these trainings and please do kind of bring them to your communities, I hope, inshallah. But I do think that the more mental health and also clinicians in general that are trained in understanding spiritually integrated care, the better off I think our communities will be, inshallah.
Inshallah. And I did share the link to Maristan in the chat box for you guys to check out. Imams tend to be a lot of the time the first responders when it comes to mental health issues in the community. So being able to train them, and also, subhanAllah, us now as a community being open to having an imam who is trained, just shows that they're open to the idea of seeking mental health treatment, or the stigmas are starting to be addressed and being broken. So alhamdulillah, it's wonderful that Maristan is at the forefront of being able to offer that training. So I've shared that link. Another question that we have is, what is the Islamic perspective on personality disorders, especially considering the hadith that Allah subhanahu wa ta'ala wouldn't place a disease on someone without a cure? What would be your response to that?
Yeah. MashaAllah, excellent. The personality disorders are really interesting. In the DSM, which is our manual where we diagnose psychiatric and psychological conditions, there's a whole section, of course, on personality disorders. And the way we're trained, at least classically in the field, is that you don't ever diagnose a personality disorder in the first, second, or third, even time. It takes time to establish whether this person truly has a personality disorder. One of the best ways I've heard someone explain this is actually Dr. Houman Kashavarzi. If you've heard of him, he's my co-editor in the book that I was referring to, the traditionally Islamically integrated psychotherapy, and the person who started this effort. And he gave a lecture to my class at Stanford here. We have an Islamic psychology course that I teach this quarter. And he said last week in the lecture he gave, it's the difference between narcissism and someone who's a narcissist. And I thought that was a really helpful explanation. So think of it like this. You can have an individual that has narcissistic, tendencies, where they are self-centered. They're definitely, the world revolves around them. They're not really attuned or willing to make room for other people, for example, and their opinions and their thoughts and their priorities. And then you can have a personality disorder, which is a diagnosable personality disorder, where this requires treatment, therapy, and actually, if a person's willing actually to come to the kind of therapy, narcissists tend to be some of the hardest to kind of bring to therapy for this. But you may be working with them at a therapeutic level that does not really bring in aspects of spirituality. But for somebody who has all of us, every single one of us, that every single human, this is what Dr. Houman was saying, every single human has some level of narcissistic tendencies. All of us do, And this is where the Islamic spiritual progress needs to be brought in. This is where we have a whole realm in our deen on the spiritual, on the purification of the heart from a spiritual perspective, the spiritual sciences. So matarat al-qulub, or purification of the heart. So you constantly have to cleanse and purify and make sure that we get rid of things like greed, envy, avarice, arrogance, all these kinds of diseases of the heart. But you're not going to find that listed in the DSM. So just because it's not there, it doesn't mean it's not real, and doesn't mean it doesn't need treatment. And so here is where you kind of need both aspects. That if a person has narcissistic tendencies, they need to do spiritual cleansing. But if they have narcissism, they also may need to have that therapy level, right, treatment as well. And I think that's important because the Islamic perspective, the person was asking about personality disorders. The Islamic perspective of this is that, again, it's multifactorial. There could be multiple things happening here, but you can't let go of the spiritual cleansing that happens in addition to any psychotherapeutic treatments as well.
Jazakallah khair. We'll take one more question. I'm actually going to combine two of them together here. Does Meristan, or do you know of any resources that offer information for youth who are struggling with mental health implications surrounding gaming addiction, social media addiction, as well as even gender dysphoria or struggles with same-sex attraction? Do you have any resources for faith-based mental health counseling, or does Meristan offer any counseling or training for mental health professionals within those realms?
Yeah, these are all really, really important topics. And there are some trainings that we can directly offer at Meristan. And again, if a person's within the state of California, because our clinical services are limited to the state of California with our therapists. And so certainly you can refer if you're within the state. And if you're not within the state, on our website, meristan.org/resources, on the resources tab, what we've put there are a list of resources of directories, other directories of Muslim mental health clinicians nationally, either by state, as if such directories exist for your specific state, or kind of national directories where you can put in your zip code or location and see what Muslim clinicians pop up. In terms of trainings, yes, we've definitely have done trainings either. In fact, I would say it's interesting. The question that came up about addiction is important because one of the newest lines of research in my lab, we have about a dozen lines of research we focus on. I mentioned a few of them, this, spirituality and religious competencies. I mentioned the one on suicide. There's several others, there's global mental health, refugee mental health. There's all these different lines of research. And one of them, the newest one, is actually on substance use or addiction, just addiction in general. And so we're kind of rolling out research that then becomes a manual. The manual then becomes training modules, just like we did for the suicide trainings. And so that's the newest line. And we're absolutely looking at all of the aspects you brought up. And so I do think that just within, down the line, very shortly, inshallah, soon enough, you'll be finding those trainings offered by Meristan. Now, in the meantime, I would say that there are some, I could point you to the direction of some either rehab facilities that have just started. It's amazing. We now finally have a Muslim rehab facility. It's also located here in California, and some efforts looking at addiction from a Muslim perspective, including a book that was just recently published on, incorporating the 12 steps that we often use for AA or, Alcoholics Anonymous or NA, Narcotics Anonymous or really any form of addiction for treatment. And it's a workbook, but it's written specifically from a Muslim perspective. So these are all resources I'm happy to share with you, inshallah, and that list of resources we'll send out.
That would be great. And we'd be happy to link all of the resources with the recording of this webinar, which will be posted on the IMANA education website. With that, Dr. Rania, we would absolutely love to have you back in the future. A couple of years back, you gave us a wonderful talk on postpartum depression in person at an IMANA convention. I believe it was with ICNA. And so alhamdulillah, it was wonderful to have you back. We look forward to having you participate in the future. And I believe we'll probably end up getting a poll with our attendees to determine what type of topic to see if you are interested and available. So with that, thank you all very much for coming tonight, and Dr. Rania Awaad especially for enjoying or spending your evening with us and talking to us about integrating faith in a clinical setting. We'll go ahead and close for the evening. سبحانك اللهم وبحمدك أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. جزاك الله خير. السلام عليكم ورحمة الله وبركاته.
Alaikum assalam wa rahmatullahi wa barakatuh. Thank you all very much. Take good care. We'll see you soon. Assalamu alaikum.
Wassalamu alaikum.